Welcome back, everyone. We're going to start our series on the pediatric patient by looking at a brief overview of some of the physiologic changes that are different with pediatric patients from our adult patients. Children differ from adults in that their anatomy and their physiology and their emotional response to things are significantly different or can be significantly different than your adult patient. Your approach for the pediatric patient should be based on the patient's age, their developmental level, and accommodation should be made to adapt to their developmental and social issues that are relevant for the pediatric patient. Some physical changes. So, in birth to 2 months, babies can begin to control gaze and turn their head. At 2 to 6 months, they can recognize caregivers and start to make eye contact. And at the 6 to 12 month mark, they begin to sit without support and crawl, and they begin to exploring the world by putting things in their mouth. Teething also begins to develop and they start to eat soft foods. On the cognitive developmental side, the 6 to 12 month old will start to babble and usually will speak their first words by the time that they're about 12 months of age. They'll start to remember objects and develop some worldly curiosity about what things do. Emotional developments are important to understand as when you're assessing patients, this may play a role in the patient's response. Birth to 2 months, trust mostly develops in the parents. At the 2 to 6 month mark, babies will begin to express emotions like joy and anger, fear and surprise, and start seeking attention. Separation anxiety starts to develop around the 6 to 12 month, and tantrums begin, and there's some self-determination, particularly while they're eating. During assessment, make sure you keep the child warm and support a young infant's head and neck as they don't have the musculature yet developed for their head and neck. You'll need to support that. Older infants will be the calmest in the parent's arm, and it's not uncommon that we will transport these patients being held by a parent or a loved one if that keeps the patient calm and facilitates treatment and or assessment. When you approach a child, if the child is quiet, then auscultate first. As you start to create stimulus with assessment, you may not have the ability to auscultate the lungs or listen to the heart. 12 to 18 month mark, babies will begin to crawl and walk. They start to imitate others. They'll play games like make believe, and they'll start to understand major body parts. They understand more words than they can express, but they typically know about 4 to 6 words or so. They demonstrate basic reasoning at this level. They start to understand things like object permanence and demonstrate separation anxiety. By 2 years, they've got an improved gait and balance. They run and climb. The head does grow a bit more slowly than the body, and some of the physiologic changes we note is that in our younger patients, our birth to 2 year patients, the head is disproportionately larger than the body. The body begins to catch up by that 2 year mark and starts to equal itself out. They begin to understand things like cause and effect. Speech picks up at approximately 100 words or so by age 2, and they demonstrate attachment to certain objects such as pacifiers, dolls, blankets, toys, whatever they have found comfort in. The pediatric assessment triangle is a tool that we use to assess children, and it starts with examining the patient from afar. Some of the strategies that we can use for examination, we can keep the patient in the parent's lap. We can get down to the child's level, have a parent assist when possible, but you're going to have to ultimately be flexible as a provider in assessing these patients, as you'll need to accommodate the child's position in space. And we'll talk more in the assessment lecture about pediatric assessment triangle specifically. By ages 3 to 5, they're becoming verbal and active at this point. They're also self-aware of their bodies, so you need to make sure that you're respecting modesty. Let the child participate whenever possible. Give them a task, give them something to do. Sometimes this helps facilitate assessment with this age group of patients. Set limits on behavior if the child acts out. Ages 6 to 12, we call these school-age children, or the term that we used is school-age children. They're capable of abstract thought and understand cause and effect by age 8. Anatomy and physiology becomes pretty similar to adults, which means we should engage the patient in discussion and treatment and information just as we would an adult patient. Ages 13 to 18 we classify as adolescents. Once secondary sexual characteristics have developed, we generally in medicine treat them as adult and this is breast development in female or underarm hair in males. Once they've reached that point, we consider them to be adult aged for medicine purposes. Address and reassure the patient and offer as much control as you can when you're dealing with this age group. As far as the head and anatomy goes, infants and young children's, the head is relatively large compared to the rest of their body. During infancy, those anterior and posterior fontanelles or soft spots are open, which can create complications for injury, so that should be part of your assessment. Take care when you're positioning the airway. Remember that occiput is significantly larger, so if you're having to pad under the shoulders to help open that airway, then you may need a significant amount of padding. With the neck is shorter and smaller in children, and the epiglottis is long and floppy, and sometimes during intubation this can create some complications when you're trying to visualize the vocal cords. Keep the nares clear with suctioning, avoid hyperextension of the neck, and airway secretions may be problematic, and so you may need to take care while suctioning. As far as the respiratory system goes, pediatric patients have smaller tidal volume but nearly double the metabolic oxygen demand. You can see a table here on the right-hand side of normal respiratory rates for pediatric patient, and while it's worth committing those to memory, remember that a number doesn't dictate respiratory sufficiency, so we should keep in mind that assessment techniques such as oxygen concentration or end-tidal CO2 capture can give us a better indication of how well the patient is ventilating and oxygenating. Infants use the diaphragm predominantly for inspiration. They experience muscle fatigue quicker and are highly susceptible to hypoxia, and this can cause cardiovascular collapse and arrest, and usually presents as bradycardia, which we talked about in some of the neonatology stuff. Bradycardia or hypoxia will lead to bradycardia, which is, if you've got a bradycardic pediatric patient, you should suspect hypoxia first, for sure. Children rely on pulse rate to compensate for decreased oxygenation and to maintain cardiac output. You can see here is a table of normal pulse rates. So your neonates are 100 to 205. Infants are 100 to 180, and it starts to drop as you progress through and get to the school-age children. At 6 to 12 at 75 to 118, and then by the time they're 13 or in that adolescent age, pretty normal as far as rate goes within the adult spectrum of 60 to 100. The cardiovascular system is limited, but there are vigorous cardiac reserves. Injured children can be in shock and maintain blood pressure for a long period of time. And what this means is they may not present with signs of decompensation or reduced perfusion for really long, but when they decompensate relatively quickly. For the advanced level providers, ECG findings and large right-sided forces are normal in younger infants, so you may see indications of things like that would otherwise in your adult or geriatric patient indicate things like pulmonary hypertension. Those large forces on the right side of the heart are typically normal in the pediatric patient, and so assess that accordingly with presentation. Cardiac output is rate dependent, and so that's the majority of the compensatory tool for children is heart rate. They don't have great control of systemic vascular resistance, so vasoconstriction is not as prominent in young children. The mediastinum is more mobile, and so there's there at a higher risk for mediastinal injuries as well. As far as the nervous system, neural tissue and vasculature are fragile in the younger children. Brain and spinal cord are not as well as protected, and the pediatric brain has nearly twice the blood flow, which makes even minor injuries significant and again increases the risk for hypoxia. For the spinal column, the fulcrum or the center of balance, center of gravity is higher. With age, vertebral fractures and spinal cord injuries in young children are not very common, but with a significant mechanism of injury, you should assume cervical spine injury and transport with spinal motion restriction. The abdomen and pelvis organs are susceptible to injury for several reasons. You've got proportionately larger solid organs and less subcutaneous fat, which provides less protection as well as less abdominal musculature, which is also less protection during injury. Adult height requires bone growth. So when we look at the musculoskeletal system in the infant or the pediatric patient, most growth plates will be closed by adolescence, but the pediatric patient does have growth plates in those bones, and growth plate fractures can be seen with low injury or low energy mechanisms of injury, and so it's just a method of consideration for patients who have musculoskeletal trauma that are pediatric, and we should be immobilizing all sprains and strains accordingly. Slipped capital foramen epiphysis. This occurs in children and adolescents. It's prominently found in overweight children, and symptoms include things like difficulty walking, noticeable limb limp, inability to bear weight on a limb, or painful or limited normal flexion and rotation. Chest and lungs. The chest wall is quite thin for pediatric patients, and the ribs are significantly more pliable. We talked about this again, some in airway and some in neonatology. The risk of pneumothoraces during bag valve mask ventilation is higher in younger patients. This is twofold. One, the physiologic structure of your patient and the general sympathetic response of the provider, the sympathetic nervous system response of the provider, causing either aggressive overinflation or a rapid rate of inflation of the bag valve mask, and creating that barotrauma. So be mindful and understand that signs are often fairly subtle of a pneumothorax in the pediatric patient. As far as the integumentary system, infants and children have thinner, more elastic skin and a higher body surface area. This complicates things, particularly with temperature management. So again, making sure that the environment that you're treating your patient in is appropriately temperature controlled to ensure that we're not getting excessive heat loss for these patients is important, and they also have less subcutaneous temperature, which also affects the ability to maintain temperature homeostasis. These things contribute to the risk of increased injury and hyperthermia, and also the increased severity of burns. Pediatric patients have limited stores of glycogen and glucose. Hypovolemia and electrolyte derangements are not very common, but make sure that we're assessing blood glucose levels on these patients whenever we suspect an underlying metabolic issue, or even things like an underlying significant infection where the patient has been at an elevated temperature or ran a fever for several days. Parents of ill or injured children, rapport with caregivers is going to be critical. Right, you're going to need to establish a rapport with the caregivers, and we'll talk about abuse and neglect later, but even in times of abuse and neglect, your job, your primary role is to treat that patient, and that may require you to create a rapport with those caregivers. So you should be including the caregivers that are on scene in your discussions, in your history, in your physical exam, and your care delivered, and so that you can develop that rapport and ultimately remove that barrier that might exist for you being able to treat your patient. Pediatric patient assessment, remember that it differs from adult assessment. You'll need to adapt your assessment skills and have age-appropriate equipment. Your adult stethoscope is not appropriate to be using on a neonate or a newborn or a small patient. You need to make sure that you've got age-appropriate equipment at your disposal. If you're using blood pressure cuffs, make sure you're using the appropriate size blood pressure cuff, and make sure you've got the appropriate size cuff if you're using an automatic blood pressure on your monitor. And likewise for SpO2 or any other monitoring device or assessment tool, you should have the appropriate sized equipment to manage your patient.